Good evening, everyone, and thank you for coming out on a Saturday evening for this case discussion series. We are on the fourth discussion this Saturday, and we I think we are liking the way we are progressing, in which we are sharing information. We are discussing our techniques, our strategies, more counseling style, our needs, requirements, and challenges as private practitioners as well. So, thank you as a community for supporting and joining in. Our speaker for today is Priyanka Mishra, and she is a speech language pathologist currently in private practice in Kanpur for the last 12 years. She runs a pediatric multi rehab center in Kanpur, Vaani Speech and Hearing Center, and Helping Hands Child Development Center. The centers have fully functional units for occupational therapy, special education, speech language pathology. A unit of Vaani Preschool, especially for children with special needs, has recently opened with the purpose of inclusivity. That is great. She is a passionate champion of early intervention and inclusion. She has been felicitated by several Kanpur NGO bodies as well as organized various programs to raise awareness about autism and other childhood language disorders. She has done both her bachelor's and master's from AYJ, and also she holds a master's in psychology. So, welcome, Priyanka ma'am. Hope you have a nice time sharing your experience here.
And so I just share the slide. Yeah.
Please do, please
So
do.
while I share the slide, I'll just brief this thing about why I have chosen this case.
Please do.
Why? Yeah. So this is something which with this case is when this child came to us, she had classic hallmark symptoms, what we call autism symptoms. She had those classic symptoms. She was into her own world. And as I tell to my parents, Swalinta, matlab she was into her own world. There was no response. And the first and foremost, when the usually the parents come seeking the diagnosis is when the child is not speaking, and that is why parents come. Maybe that is the first time when they come to us, they come to know about what is autism. This term also they hear from us maybe for the first time. But the first and foremost thing is the child is not speaking. Now the child is not speaking is something which will come very later. First, we have to manage so many things when the child with autism comes to us. So here we had to manage the parents' expectations. First of all, the acceptance, breaking that term and that diagnosis to them, because the mother was a very anxious parent and she wanted everything like she's not speaking. Let's go to a speech language pathologist. She'll start speaking. So she had gone first to a neuro. She had gone to a pediatrician. From pediatrician, she got referred to a neuropediatrician. Then that neuropediatrician had sent her for MRI and CT and BERA, everything. And she would not get anything in all those reports, of course. And then she came to us through word of mouth with this let's go to a speech language therapist about this. Now, here she was already running here and there. Now, here I had to break the diagnosis. I had to tell her how her journey would be. And then, because here many a times parents become so anxious, they don't know whether they are being fooled or really this is something, or what therapies they should go for. Now they have to be counseled about that also. The child is not even sitting at a place at this point when the child came to us. The child was running from here to there, and the child was not looking into her, the classic autism. So now I have this study, a longitudinal, like 3 years study. This child has been with us at our center for last 3 years. So I have seen a growth in her. Now there may be certain things which are not matching, parents' expectations, but for us, it's a big thing. What she's achieving right now, we are so happy the way she's progressing. Parents still have very high expectations because there are sensory issues that need to be managed. And when there is always a chance of regression, if if screen is given more or something. So she may regress also, because if she's not attended to, she may again tends to go back into her own this thing, because parents have this expectation the child should talk, hold one-to-one conversation. When I ask you, how are you? They may answer, I'm good. But they are not asking, how are you, mama? Why are you sad? They may feel that feeling, but they may not ask. So here we have also to set the expectations, how your child would be in, long span of time. So therefore, I have chosen this case, and it is still going on. The therapies are still going on. We have a long way to go still. But let me just show you my last 3 years here, how we, uh, like we managed and we did the therapies. So I'm sorry.
Arms up करो, arms up, up.
Mm. So the child reported to our center in October 21 with chief complaints of the child not following commands, no eye contact, as I said before. So she was referred by a neuropediatrician, and she was MRI, BERA reports showed no significant findings, no hearing loss. Then the psychological assessments were done. On ESA, she scored 118, which suggested moderate autism. On VSMS, the social quotient was 45, and the social age was 1.2 years. The child was at that point 3 years of age when the child reported to us. And the DQ and the developmental age came as 14 months. So, following the psychological assessment, she was suggested occupational therapy, behavior therapy, as well as speech language therapy. So, when we offer the early intervention services, we offer all these three services at our center. And so we suggested that she should go for intensive early intervention therapies, because she was very small. Still, we could capture that, that early language age was there. So we could, that critical age, she was falling into the critical age. So let's start with all the early intervention therapies so that we can capture on her age. So the speech language assessment, the oral peripheral mechanism, she had no structural abnormality. She could chew well, suck through straw. We could not check the tongue movements as she was not cooperative, as well as she had no imitation skills. The speech and language skills, here she communicated mostly her basic needs through crying or taking the caregiver towards the desired object. She did not point or follow any commands. Her attention was very fleeting, and she was not sitting at a place to complete any task. And she had very fleeting eye contact. She was not looking at face. So the therapy plan for the first 6 months, it was a very basic therapy plan. We had to make connection with the child first, that the child should acknowledge that we are there. She should be feeling safe to be in a room with us. There should be no forceful anything doing with the child, and let her, it was mostly, child-led therapy, that what she had interested, we were modeling, we were like talking parallel playing, we were something engaging in parallel playing. And so we had to gain that what we call that trust of the child in the first 6 months. Then we had this goal of imitation skills, basic motor movements, and few basic sounds, or if she could do mouth movements. So then develop attention and task completion. As I said, she was not sitting at a place. So our first goal was that when we give her something, she should be able to, at least complete that task and to finish. I did it. So that should be there, so that at least we could make her sit at a place and make her look at things, and then we can talk, that connection would be built. And then the receptive vocabulary for 4 words like de do, bato, rakho, up, down, clap, finish. So those 4 words vocabulary, that was our basic first 6 months therapy plan. The role of OT here was very imperative, very important. All the autism cases, when I take, I make sure that they have this OT. without occupational therapy, I usually don't start the speech language therapy because the sensory issues need to be managed for these children. If these sensory issues are not managed, then they may not sit at a place, and it becomes quite difficult task, as well as it's too much for a child to ask for. If the sensory issues are not managed, how would the child pay attention to what I'm talking to? So here with our OT therapist, we had a plan to manage her sensory issues, what were her sensory issues and all. So we were regular in touch with each other. How is she doing in your session? And she was asking, how was she doing now in your session? Then I'm telling I'm facing this challenge. She's, rubbing her hands throughout the session, or she's, orally seeking something. Then she could put that in her plan to manage that. So So our therapy was mostly play-based. We used also a lot of sensory activities also in the session. Like we had those sensory books where she was touching, and then she used to throw it away. But anyways, we used to give her. At least she should be able to touch it and she should feel comfortable. And so we did a lot of sensory activities like from the sand, taking out puzzle pieces and then fixing the puzzle so that she had an interest in puzzle also, like puzzles and finishing that activity. So with those sensory tools, we could make her sit down for an activity and finish that activity. And so, as I said, it was always following the child's interest. And M seemed to be analytic language processor. Like we have a lot of autistic children who come to us with jargon speech. We call them like we are talking a lot about this nowadays, like Shah's language processor, but she was analytic because she had no word, and I could see that picking up one thing at a time. So we used that bottoms up approach. Like we were teaching her babbling, mouth movements from there to go for one word. So that way, I thought we would be developing her speech like that, the bottoms up approach. So now after 6 months, the child was sitting through the session and she was getting engaged in the activities. She was looking at me whenever I was talking. Though that's not a lot of time our goal, but if the children get connected, they look. I feel that they look. If they get connected to us, they start looking at us. So that way, I was happy that she's looking now at me. And when she started looking at me, then imitation, of course, increased because now she was looking at my mouth, what I'm speaking. So, and then she started following commands also, like rakho, de do, bato, and she started common words, clap, come here. She started responding to her name as well. Imitation skills were developing. She was imitating most of the gross motor movements. So we started imitation of sounds like ah, oo, ba, 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 pa, pa. Then we eventually go towards the sounds of animals, sound of vehicles with lot of gestures and all. So they may pick up gestures or they may pick up speech, like taking the object to our mouth and then pointing and then showing our mouth and then showing that object. So that way she started connecting. Okay, this is cat and the cat says meow meow. So now she's connecting and then she's also. So a big icebreaker was the imitation. I feel for all the autistic kids, the biggest icebreaker is the imitation. Once they start imitating, I'm so happy. Now I'm going to see a good progress in the children because now they are imitating. So that connection has formed. They are now recognizing there is someone existing, like someone whom I can, like talk to or follow that person's lead. So that came, and I was very happy. Yes, now we are progressing in the right track. So she started using gesture also for they do when she wanted something, and she started pointing at things. When I asked where is apple, though she was pointing. Where is bus? She started pointing. So now the next for goals for the 6 months were to focus on increasing her receptive vocabulary more through language modeling, expansion, naming, as well as the next 6 months were parental counseling as well as teaching parents about the language techniques. These were previously also. What I do is I keep on sharing the videos and everything, and maybe the parent may sit in the session also. So then teaching them how you should talk to the child, how you should be always on the eye level of the child when you are talking. Don't talk across the room because that sets for failure, the task for failure if you are sitting across the room and asking the child to do something. Make sure you touch the child when you are talking to the child or playing with the child. You must touch the child. Gentle, prompts should be there. Physical prompts should be there. Verbal prompts should be there. I would be coming to that. What are physical and verbal prompts? So those were the techniques that we counseled to the parents. By September 22, the now M could name most of the common nouns and verbs. She could name them, and her MLU was mostly 2 to 3 words like I want car, uh, I am going. Like she used to say my name, her own name, and so Mahi is going. I want car. Like, Mahi does not want, like that, something like that. No, something like that. She started speaking, but she lacked any narrative skills. She did not use any adjectives. She did not use any descriptive language. Her social skills were lacking. She did not mingle with other kids or play cooperatively with other kids. So we started introducing the group therapy sessions for her also, where the goals were turn taking skills, then waiting time, then interacting with other kids. Also, as her speech and language started developing, we noticed her speech had lots of misarticulations. And so we did this oral, we just checked for her motor movements and we saw that her tongue movements were not proper. She was unable to elevate tongue. S, sh, r, l, w, and these words were basically misarticulated. So now again, our goal was to increase her mean length of utterance. Again, we use a lot of physical prompts, expansions, now role play, as well as we started the tongue exercises as well as repeated syllable practice for her articulation because she was imitating. And so we started giving her prompts like putting something, ice cream mistake or lollipop, and telling her to touch her tongue up, take her tongue up and sideways. Tongue, taking her tongue up required lot of practice as well as lot of determination from her side also because she was not able to do that. So we had to give her a lot of prompts again and again to take her tongue up and then to say la, ta, na. So that way we started. Sir, sure, still is not there, but we started with ta, la. So those were sounds we started with. By September 23, she was able to tell about herself. She was able to describe a picture in 4 or 5 word sentences. She was able to understand most of the day-to-day questions. She could narrate poem and story, and she could understand questions. But still, she needed a lot of prompts for those things. It was not always key if you could ask her and she would say, because she had a lot of sensory issues. Maybe her attention may be lacking at that point. She may be needing a lot of prompts. 1 to 1, when we are doing interaction, she was doing very good. But if there are 2, 3 people and when they are talking, she may not be able to, she may lose her focus and she may not be able to answer at that point. So, and she lacked a lot of pragmatic language skills like requesting, reporting a past event, or talking about absent objects. What was before her eyes, she could say, but what was not before her eyes, to take it out and to tell that, that needed again a lot of challenge. That posed a lot of challenge for her. So we introduced a lot of storybooks, descriptive cards, social emotional stories. So now at present, Mahi is 6 years. She's going to a regular school and she's in LKG. She has regular occupational therapy sessions. She has special education sessions, she has speech language sessions, as well as group therapy sessions. We are at present working on narrations, requesting, reporting of past events. Still a long way to go for her speech and language to develop, as she lacks a lot of pragmatic semantics that are age appropriate. She's not at all age appropriate, but with her to gain, I may say she is around 3 years in reels. If you see, if we do reels, she may come into 3 years for reels, and her receptive skills maybe a bit above that, maybe 3.5 years. So here the main challenges are parental acceptance, managing sensory issues, managing behavioral issues, and regression. So she had a lot of behavioral issues also. She still has, like, there is a lot of adamancy that if I don't want to do, she won't do, she will not do that. So that poses a lot of challenge in her academic skills. We had to face a lot of challenge in pencil holding in the special education sessions. Like, she did not want to, she used to throw things. When she did not want to do, she used to, still she sometimes does that, a lot of temper tantrums she throws. So maybe speech language would improve, so those will also go away. And so we are managing all those things. Let's see some of the videos which are taking along the way. So this was just a month when she came. So I was making her sit and letting her, just listen to my speaking and just.
चलो मांगो दो 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 दो.
So here, at least she was holding me, touching me, and sitting. So that was a big, and she was at least listening to me. Otherwise, when she came, she was not ready to sit, and she was constantly, putting things in her finger in her mouth and trying to vomit. He let her go away. So for me, this was also a big thing. She was sitting and touching me. Otherwise, she did not even want me to touch her. And she was constantly trying to cough and trying to show that I'm going to vomit so that mother can save her from the session. So that was there.
What is your
This
name?
is April 22.
He. What is your name? Oh, good. High five. Yay.
Now this is December 22. She's enjoying the session. Now she's attending. Her receptive vocabulary has grown, as you can see.
Arms up करो, arms up, down, up, down, round, clap, tap your head, very good. Eyes touch करो,
हेलो
eyes touch करो, touch your eye,
हेलो बोलो हेलो
nose,
हेलो बोलो
nose,
हेलो
ear,
हेलो
mouth,
क्या कर रहे हैं
feet,
हेलो
tongue,
हेलो
hand,
कैसे करेंगे
hand, very good. Legs,
व्हाट इज योर नेम
very good.
बोलो
Where's Mahi कहाँ है? Mahi, very good job. Give me high five.
Now
Good
here
job.
we are
Well
working on
done.
auditory attention and working memory.
सब करो आप. What is it? Pencil. इधर देखो. Pencil. Ice cream. Banana.
इधर देखो, look at
केक
the
बॉक्स रखो केक
हाँ banana, ice
चैरी
cream,
मैम को बोलो चैरी
pencil. Okay, चलो आइसक्रीम दे दो.
फर्स्ट बॉक्स रखो
आइसक्रीम, 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 बनाना, बनाना, good.
कैरेट मैम को दो
Pencil,
कैरेट
good job. Color,
कैट मैम को दो
color,
कैट मैम को दे दो
orange,
पेंसिल बॉक्स में रखो पेंसिल
orange,
बस मैम को
cow,
दे दो बस
हाँ, cow, orange,
केक बॉक्स
color.
केक
चलो color दे दो.
पैरेट
Color, good. Cow, cow,
बॉक्स में रखो शर्ट
good. Or
शर्ट
orange, good job. Give me high five. High
So
five.
this
What
is
is your?
last year Independence Day. She was reciting a poem.
What is it?
She needed a lot of verbal prompts for us, but it was a great achievement on her part. At least she was standing at a place and saying she was understanding what the task is, and she was saying that poem, and she had prepared it at home, and she was able to recite it in front of so many people.
मुन्ना राही वे एरोप्लेन कहाँ फ्लाई करता है एरोप्लेन कहाँ फ्लाई करता है एरोप्लेन क्या करता है फ्लाई करता है स्काई में हाँ अब बताओ स्काई में क्या फ्लाई करता है माई स्काई में क्या फ्लाई करता है स्काई में क्या फ्लाई करता है स्काई में क्या फ्लाई करता है स्काई में हाँ ठीक है ये गर्ल के हेयर खराब है ना गर्ल के हेयर सब मेसी है खराब है खराब है तो क्या करेगी वो क्या करेगी हेयर खराब है तो वो क्या करेगी वेरी गुड कोम करेगी कोम करेगी तो हेयर खराब होते हैं हेयर खराब होते हैं तो
मैंगो बेटा ये ग्रेप्स है मैंगो मैंगो
क्या करते हैं हेयर खराब होते हैं तो क्या करते हैं
मैंगो
बोलो कोम करते हैं
और एप्पल
हेयर ये गर्ल के हेयर
Here actually, and so we teach them through flashcards, and then maybe we try to give them the real things also, and then we ask the parents to generalize at home also with the real object how the child is doing most of the time. So this was journey of M to 3 years, and so now the case is open for discussion.
If anybody wants to put in any anecdotal points, you want to ask her anything, please either put it in the chat box. Try doing that. You could also unmute yourself if you want to ask her anything directly. Ma'am, till that time, I would like to put forth 2 or 3 points that you said. So, among the this thing of the parental, counseling the parents and working with the parents, like you said, now when a child is coming to you, ma'am, can you stop the sharing? Will that be okay
Yeah,
if it's?
sure.
Huh.
Yeah.
So now when any kid comes to us, like working at speech and language is almost the third or the fourth priority. Like before that, you're dealing with so many things. I specifically wanted to ask you 2 things about how this set of parents reacted. One, the 6 months that we would like for connecting with the child, for the child to trust us, for the child to even work with us. Some parents take it as, "अरे ये तो बहुत time है, we are paying so much for so many sessions."
Very
One.
true.
And also, ma'am, the other thing would be the number of services you recommended. Was there any hindrance or doubt from their side कि, now that we have come, इतना क्यों refer कर रहे हो? Why are you making me do so many things? Ma'am, can you shed some light on that?
Yeah. So has been a challenge, and especially in private practice, when you have to,
Yes,
take, the parents are paying you and they are
correct,
paying their hard-earned money. So now you have to
yes,
justify your services. This
correct.
is a major part of our practice.
Private practice,
Actually, the therapy skills, they form a part, but this is in a private practice. This makes
correct,
a huge part of what you are and how you are trying to tell the parents, not sell. I won't say sell, but I would always say how you are counseling the parents. That becomes a big part. And make the parents understand, see, this is the right way, because there are a lot of quacks also who are claiming to be therapists, all the therapists in one, speech therapist, occupational therapist, special educator. So we are fighting a lot of quackery over here.
yes,
So now here, first of all, I made the diagnosis of autism very crystal clear and set a very realistic expectation to the parents. I sell no sugar-coated words. I tell,
correct,
see, this is autism. And you must go to certain sites, Autism Speaks or something like that, to trusted sites where you must learn about what is autism and what are the therapies which a child with autism should have. Don't
correct,
trust us. You go home, you do your research, you see, but you see only like Asha, go to Asha site, go to
correct.
Autism Speak site, see
Hmm,
how what they are speaking, what they are telling you. Don't go to any
correct,
YouTube and just search autism. So
correct.
that is there. Then we tell about the sensory issues. We see, they always ask us, speech kab aayegi, ma'am, speech kab aayegi. And 50%, let me be very clear, when lot of kids come, with autistic, 50% may gain speech and 50% may not.
Absolutely,
And
absolutely.
then it becomes very difficult for us to justify why we are doing speech language therapy if the speech is not coming.
Coming,
So,
absolutely.
so now I always teach the parents what is language and what is speech. So I
Correct,
tell them, see, we are developing language. Don't talk to me speech. Speech
correct.
is not what we are working on. We are working on language. And
Hmm,
language means receptive language. Even if your child is not speaking, you just remember, you just see the kind of difficulties you are facing imagining your child. And with
hmm,
the speech language therapy, you will see lot of that management of the child will
hmm,
become easy because the child will start following your language. That, like,
correct.
at present you are speaking a foreign language with the child, and then
Hmm,
the child will start understanding.
correct.
So I always give this example. See, if you are a Bengali speaker or a French speaker, you are going to a new place, you
Hmm,
may start understanding French, but you may not start speaking French,
hmm,
just to tell the parents. So I tell them, so the child will start understanding your language and
hmm,
your lot of problems will just disappear. Now Mahi, like, she is understanding so much. So now
correct.
the mother herself is telling my so many problems. I tell her, come. Mahi said, Abhi ruk jao, baad mein chalenge. She's understanding. Maybe she's not speaking. So
Correct.
speaking, I suppose sometimes that word retrieval problem is also there. They,
Hmm,
when the thing is there in front of them, they are able to say that. But
hmm,
when it's out of sight, they are not able to retrieve that word. We had this tip of tongue thing in linguistics,
phenomenal.
like it's
Correct.
there, but it's not coming. So
Correct.
there I tell them you need to bombard them again and again and again and again with that word, and especially with the functional words. So maybe
Correct.
they will start. So I just tell them about all the services, why they are required, and one
Hmm.
good thing is at our center, all are trained therapists. Like we have a proper occupational therapist, a proper RCI certified special educator. Then I keep one counseling session with them also. So
Okay.
now the parents are, okay, I need this session also, I need this session also, I need this session also. Then we
Correct.
try to make it like pocket friendly. So how many
Huh.
sessions for this, how many sessions for that, something like
Correct.
that. So that
And
is there.
huh. And because, like you said, when you start off with speech language and you're intervening a child for the first time, like this was this case that you described. Without OT, we are very helpless without OT basically. So that OT is required, and not just that, we have to tell the parents, ये सब घर पे करो, otherwise the child's regulation is so affected, the right child cannot connect with us at all.
Very true. Very true. So sometimes if all the services get very difficult for the parents to do, I don't tell them to go for speech because the child may not sit and the parents think that session is wasted. The child is just running, though they don't understand. Maybe few parents do understand. Ki even if the child is
Correct.
with us in the room, also that is also a
uh,
win-win situation.
Correct.
But I just tell them you go with OT for a week. The child will
Mhm.
settle down. She will come to know. Then I will go and try to introduce myself. Then the
Correct.
child will maybe, try to uh, um, get accustomed to the center. Then we try to, introduce one sessions at a time, something like that.
So, ma'am, Mitali Sharma here is asking, would you say that her cognition was affected too?
See, usually we do IQ testing. Also, we do
Hmm.
after 5 years. We don't want to label the child. DQ was coming less
Correct.
at the time of
Ah,
when we did that, but
correct.
DQ and SQ. But we don't do the IQ testing. But
Hmm.
after 5 or 6 years, if the child is facing significant learning problem, then
Hmm.
we go recommend her for IQ testing. Cognition, I would say not affected per se. Why? Because in the special education, she was doing very good. She was understanding she's doing Hindi. She's even understanding matraएं, the choti, badi, oo, ah, and
Okay.
everything. So the special educator is saying ki she's doing good, ma'am. So maybe we could refer her for IQ testing so that we may
Hmm.
say that if her cognition. But right now, since she was in early intervention, we just wanted to do all the services. We didn't want to burden with further
Correct.
testing or something like that. Because in private practice, we need to see. We can't refer them. Keep on referring.
Yes, yes, ma'am. Ma'am, even the truth is that even if the child is moving on to a different school, tab jaake sometimes even at 11, 12, do they get the IQ finally done because they are
Mm,
understanding that they are not able to manage in regular school. And then, so
yes.
it is, we anyway don't have a standardized protocol from moving from service to service. It is mostly the parents' convenience,
Mm,
or if the school infrastructure is not able to support them. So anyway referring, and then the parent will again have a huge lot of questions for us, ये करने से क्या होगा, and what
yes.
yes,
Yes. Yes.
what benefits are we going to get, and things like that.
Yeah. Yeah. Right. Right. So therefore, we don't push for the test, but yeah, we do that. Yeah.
So
3D lab.
हाँ.
Yes. 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 We can definitely do that. 3D lab. Yeah. Otherwise, we are doing a battery of tests like GDT when the child Jess's drawing test when the child is 3 years. But yeah, this is a good tool that we can do below 1 year. Yeah. Thank you.
Ma'am, even this thing is there. Even the ComDeal's developmental checklist is there, and it basically transforms into a graph for the parent to understand ki gross motor, fine motor, then the understanding talking kidhar hai. For the therapy, we may
Mm-hmm.
not stick like you described. For the therapy and how we move in
Mm,
therapy, we may not be able to stick to milestones, because a
Hmm.
child on the spectrum is not going to develop according to
No, no,
neurotypical milestones.
no.
But for initially explaining the parent the COM-DEAL checklist, it becomes a graph basically.
Hmm.
So
Hmm.
that is a very nice visual representation for parents. Like you
Okay.
said,
Yeah.
there could be word retrieval problem, there could be even apraxia issues that we'll figure out
Hmm.
much later.
Yeah, yes, very true. Apraxia is a very common thing in what I am discovering. I am learning every day in my private practice, every day. So this is something I really enjoy. So apraxia is very common. So now we are
Correct.
doing both of the things therapies. Like Mahi also, even I feel she has components of apraxia, the way she's
Yes.
speaking, as you could see in the video.
Yes. And
So,
ma'am, and the more they work with us, the more things we keep finding. So that is the reason
hmm,
having only one evaluation battery is not going to help in private practice. You are continuously evaluating.
hmm,
And then there are things
hmm,
like apraxia, which does not go on a formal report anywhere to actually
hmm.
help the child that, this child has this problem as a
Yes,
reality.
very true. Yes, yes. Yeah. Apraxia also, like what I have seen, this para khadi, like you had discussed in the previous, this really
Yes,
helps in apraxia also.
yes.
So
Because
we
what you
try to
see
do
is
lot
what you
of,
because what you see is what you say. The Sanskrit based whatever we have, the Devanagari script. What you see is what you say. It's not English. You write O, but you say something else. You are writing A, but it's A. It is so difficult for our kids,
yes,
basically.
yes. So, so sir is asking Indranil, sir, what is the prognosis for this child, like
Uh,
mild to moderate versus severe one? So usually what is the prognosis?
yes.
So I have seen lot of children, as they say, reversal is not there in autism. Autism neurotypical and neurodiverse.
Hmm.
Hmm. So, but I have seen lot of kids coming with when I do INSA, when we do INSA, they are checking on a lot of things which are, they are on the autism trait. And
Hmm.
if they are below 3 years of age, and
Hmm.
I've seen early intervention services work like magic. And
Correct.
children just, those things just go away. And in 6 to 8 months, lot of
Hmm.
children have just, gone back and the languages started emerging and lot of, they started like a normal school. But yes, that neurodiversity is always there. So I always counsel the parents, if I'm terminating the therapy, see, you don't have to just sit down like, okay, now my child's speaking, now I can just chill, I can give her Miscreen or something.
Correct.
Once you leave the child, or God forbid something happens, or you are not able to talk to the child for, like, if there is birth of a newborn, or there is death in the family, and you are not able to talk to the child maybe for 10, 15 days, and the child is left to their own devices, it may reverse. And I've seen those kids,
Yes.
they just go back. They have started speaking, they have developed eye contact, they are doing everything, and now they are just left on their own devices, and then again they
Yes.
start. So that
So,
neurodiversity is always there.
yes.
So the prognosis is like that. With moderate and severe, after certain age, when the children come to me, like after 5 years, 6 years, I always tell the parents blankly, see, if the speech is not there, I don't think the speech is going to develop. It may develop, but
Hmm.
I'm not sure how much the language expressive will develop.
Will
Though
develop.
we
Correct.
can work on the receptive language, and it develops. The receptive language develops if we work diligently, even with 5 year,
Correct.
6 year old child, the AAC and everything. But
Correct.
don't expect me that the child will start speaking like that. So I
Like
give
magic.
that,
Correct.
a disclaimer when I start the therapy.
Absolutely. Absolutely, ma'am. That is the whole point of explaining the neurodivergence, that the wiring, the physiology is different. You cannot be sticking to the neurodevelopmental milestones and markers. Like you said, you don't have interaction, and the child will be doing several different things. There could be sensory seeking, there could be behavior, and it is ultimately the child's frustration. So we can't say, "अरे वो तो कर रहा था." There was a lot of help which allowed the child to actually flourish, and then it
Yes,
goes back. Correct.
yes, yes.
Okay,
So,
so ma'am, I'll just Thank you so much. I hope the discussion was also fruitful for all our participants. I'll just share this with you. I'll send this to you
Thank you
personally
so
across
much. Thank you
as
so
well.
much.
It's a very small token of appreciation for you. And
Yeah, thank you so much.
thank
Yeah.
you for coming and doing this. We
Yeah, it
have
was very nice for me also, to share the things, because it's always, we learn a lot with after sharing
unexpected.
and we
Yes,
talking, communicating.
absolutely,
Yeah.
absolutely. So, ma'am, please stay with us. I'm discussing a journal article next. So, I hopefully this will be clinically useful to most of the people attending today. So, I'll just share the screen. Um, So the reason I picked out this particular article, it is open access. You can download it. And once we are done, I can put the link in the chat box. So all of you can download it and read it. It's a 21-page article, and I'm trying to proceed, summarize it so that we are done in the next 10-15 minutes. You are free to read it at your own leisure. I will obviously be missing out quite a few details because I'm the one, because we are trying to finish it and it's a summary. So using telegraphic input with children with language delays, a survey of speech language pathologist practices. So these are the three authors, and we are going to shortly look into how the SLPs were picked up as well. So although using simplified input is a common practice among SLPs, there has been some controversy regarding the most effective way for us to simplify our utterances, and particularly when working with children at pre-linguistic one-word and two-word stages of spoken language development. This controversy has primarily centered, one second, I'll blow it up, primarily centered on whether simplified utterances should be telegraphic or whether they should maintain grammatical rules of English. Telegraphic utterances contain content words, nouns, verbs, but eliminate function words, that is, articles, auxiliaries, similar to young children's production during the early stages of language development. Ball under, doggy, go, more, toy. In contrast, simplified grammatical utterances maintain grammatical rules of English. The ball went under, go doggy, more toys. So, though the evidence from clinical studies remain limited, several recent studies have suggested that grammatical input may offer some advantage over telegraphic input. Despite growing empirical attention to this issue of telegraphic versus grammatical input, we know very little about how practicing SLPs simplify their language input and why. So there are a few categories before we actually go into the research to look into. I'll try covering them fast. Producing verbal imitations, one of the things we just looked into the previous case that was discussed. One of the most common theoretical arguments made in support of telegraphic input is that telegraphic models should be easier for children to verbally imitate than grammatical models. Despite the popularity of this claim, there appears to be very little scientific evidence to support it. Children presented with reduced models, this is a study which is described here. Children presented with reduced models showed better verbal imitation than children presented with grammatical models, which has led some to interpret as providing support for telegraphic imitation prompts. That if you reduce the length of if you are reducing the phrase, it is definitely easier for the kids to pick up. So Braden, Oja, and Fay examined the effects of telegraphic versus grammatical imitation prompts on 5 children with language delay. Children were equally likely to imitate both types of prompts, showing that the use of more complex grammatical prompts did not discourage children from attempting to imitate the adult models. So these findings led the authors to conclude that grammatical prompts are a more advantageous treatment strategy because they allow children to produce grammatically complete utterances when they are developmentally ready. Again, something which was covered right here in this previous case discussion, that you may be understanding this and they will be able to utter it when they are ready. Understanding spoken language. Another theoretical argument made in support of telegraphic input is that because telegraphic utterances include content words but eliminate function words, they are easier to understand than grammatical utterances for children with language delays. Although this argument is reasonable, to our knowledge, there is no scientific evidence to support it. In fact, studies of children with typical development provide evidence to the contrary that grammatical input is easier for children to understand than telegraphic input. So this is a French study described here, which found that the presence of articles helped infants recognize subsequent words. Similarly, in another study, they found that the grammatical utterances elicited faster processing in 12 to 18 months old with typical development than telegraphic utterances did. And these findings indicate that utterances containing more information are not necessarily difficult to process than those containing less information. In addition, this evidence illustrates that function words support language processing in infants and young children at a point in development when they are not yet producing these function words themselves. Then comes identifying word categories. So Bedore and Leonard suggested that grammatical input supports children's learning of word categories through a phenomenon called as prosodic bootstrapping. The theoretical rationale is that prosodic patterns in grammatical input, such as the presence of a weak versus a strong syllable, may help children to make inferences about new words that they encounter. For example, in the word baby, the second b is significantly, it's a weaker syllable, the second b. So then comes learning words. The presence of syntactic cues in grammatical input, such as function words and grammatical morphemes, plurals, may also help children learn the meaning of new words. Many studies are focused on children with typical development, but children with language delays, autism spectrum, and developmental delay are also capable of syntactic bootstrapping. That is, learning because these other things are present in what is being presented to them. So learning grammar. So the issue is this limited exposure is potentially problematic because as a general rule, children with language delays or impairments may require increased exposure to language in order to learn effectively. Our exact role. So potentially, fewer exposure to grammatical markers and function words may make language learning even more challenging for those for these children, potentially explaining why higher rates of parent telegraphic input are associated with weaker language outcomes in children with autism spectrum disorder over time. They also suggested that prolonged exposure to telegraphic input may extend the period in which children with language impairment exhibit difficulty in learning obligatory grammatical markers and may lead children to interpret telegraphic models as an acceptable variation of adult language. So in the evolving clinical recommendation, for example, here there's a research by Eisenberg that states that research evidence does not support telegraphic input, but rather suggests that we should produce grammatical morphemes when we talk to children. And Paul et al. Made a comparable recommendation stating that whenever the intervention approach, whatever the intervention approach we use, the linguistic input ought to be complete and well formed. So, so this was for the complete grammatical input that, make your phrases grammatical, make them short, don't make them telegraphic, under, sofa, not there, and things like that. There are two models which are then being discussed, which is the Early Start Denver model and Project Impact, where a comprehension intervention for young children with autism spectrum disorder, which recommended the use of such phrases, want bunny, more ball, etc. And Project Impact, a parent-mediated intervention focused on improving young children's social communication skills. So these are two these things. Then so interestingly, several intervention approaches that previously incorporated telegraphic input now recommend the use of simplified grammatical input. So for example, programs developed by the Hannon Center formerly suggested the use of telegraphic input, but now teach parents to use utterances that are short but grammatical. So I think there's a similar description is given about the milieu approach as well. So Many clinical recommendations have included only which type of input to have included not only which type of input should be used, but also for which children. I think the next thing as SLP is what we think is large part for the previous recommendations, which were based on children's spoken language abilities. Miller recommended that clinician input should be initially telegraphic, but as the child began to use syntactic constructions, the clinician should transition to fully grammatical sentences when expanding and modeling utterances. It has also been recommended that clinician take the cognitive ability in account, as the children with intellectual abilities and average range may not benefit from telegraphic input or may only benefit for a limited period of time. In contrast, few recommendations have focused on children's language comprehension, though some have pointed to the need to understand more about this issue. So, about the current study. So, the current study addressed three research questions. To what extent and in what therapeutic context do SLPs report using telegraphic input when speaking to a child with a language delay? To what extent and in what therapeutic context do practicing SLPs feel it is useful to produce telegraphic input when speaking to a child with a language delay? And what child characteristics do SLPs view as most important when deciding the type of language input to provide? So the SLPs were basically survey respondents were recruited from the university sponsored professional development conference focused on current best practices in speech language pathology. And 93 respondents, there were 93 respondents. It was a survey. The respondents completed a survey in a median of 23 minutes, and it was administered on something called as on RedCap, an electronic platform for survey design and administration. The current study focused on questions about practices and perspectives pertaining to language input. We are going to look at the appendix after this. And for the section of survey focused on language input, respondents were instructed to focus on children with language delays who are pre-linguistic, not yet producing spoken words, or that they are in the one word or two word stage of spoken language development. They were also told that content words refer to noun, verbs, adjectives, and prepositions, and function words refer to determiners, and grammatical morphemes are plural, third person, singular, in. These definitions were included to ensure the respondents understood the terminology that was being used. Please note that they did not use the term telegraphic input in the survey. So instead, respondents were asked about utterances that contain content words. So this was not to bias the respondents, basically. So I'm not going over, I'll reduce the size for you to see. I'm not going over the results, which are question by question, and there are the statistical information is given, how they processed it question by question. I'm putting it up in the chat. I'm putting up the link to the PDF in the chat. You can definitely read up the whole thing. We'll jump onto the discussion. They have done proper statistical testing for us to understand or take away a few things from this study. Consistent with our expectation, the vast majority of SLPs reported using telegraphic input with children with language delays. In fact, over half of the sample indicated that they use telegraphic input sometimes, often, or always. Only 18% reported that they never produce telegraphic input. So they reported using telegraphic input most often when prompting for imitation, when we prompt for a specific word only as an answer, possibly. So although many SLPs reported using telegraphic input, relatively few SLPs viewed it as useful. In fact, only 30% of SLPs who reported using telegraphic input agreed that it was useful, indicating a considerable mismatch between practice and perspectives. And analysis revealed a significantly larger discrepancy between using the telegraphic input and viewing that input as useful than using shortened input and viewing shortened input as useful. Neither set of findings revealed 100% agreement, pointing a need to work towards more reflective clinical practice and purposeful decision making in the context of simplifying language input. Despite the existence of these discrepancies between practices and perspectives overall, the mismatch between practice and perspectives appear to be particularly pronounced for telegraphic input. Why did so many SLPs report using telegraphic input, and why did so few SLPs view it as useful? There is no good answer to it, definitely, but one potential explanation for the mismatch between practices and perspectives is that SLP's attitude towards telegraphic input changed over the course of the survey. So this was one confounding bias of this particular survey. So it has come to our attention that many SLPs have not thought a great deal about the distinction between the two, or about relative strength and weaknesses of each style of input. Completing this survey may have led the SLPs to reflect on the relative merits of telegraphic versus grammatical input more thoughtfully than they had in the past, leading them to question the usefulness of telegraphic models. It is also possible that the responses were affected by a difference in wording of the two questions. Questions about practice focused on clinicians and questions about perspective focused on adults, that is, parents and clinicians. It is unclear whether SLPs are aware that some clinical researchers and intervention approaches are currently recommending grammatical rather than telegraphic input. It is also possible that some SLPs use telegraphic input despite uncertainty about its efficiency, because they do not know which type of input has more empirical evidence to support it. Then comes finally the examination of the child characteristics, that is so important. So receptive language level was rated as most important characteristic to consider, followed by the cognitive level, expressive level, and finally the age and diagnosis, which did not differ. So SLP's responses suggested that when deciding how to simplify their language input, they focus more on what the child can understand than what the child can see. After all, children can understand a great deal more than they say, and unnecessarily limiting a child's exposure to well-formed grammatical utterances could potentially lead to further delays in their language development. So, okay, so I think this is the last bit. Then, so for future discussions of telegraphic versus grammatical input, we suggest that it will be critically important to consider the distinction between length and the grammaticality. Utterances can be simplified but still maintain grammatical rules of English. My ball, more milk, go car, running fast, open it, under the table, all maintain grammatically within shortened utterances, and they do not violate the grammatical rules. After all, single words are often produced in everyday conversation that are entirely acceptable. Do you want orange or blue? Blue. Thus, it is clear that length and grammaticality are separable constructs. So I'll just scroll down and just show you the appendix. So initially, it is about the career, the position, and what kind of caseload is there, and things like that. And then is the actual language input. When speaking to the child with language relay, do you shorten your sentences? And when describing a child's play, the commenting, linguistic mapping, what is your utterances when you're prompting for to verbally imitate? You shorten your utterances for providing a directive or a request. And when speaking to a child, do you produce utterances that contain content words to eliminate function, or dog running instead of dog is running? So there are several more, which I think which made the SLPs really evaluate their own practice when they were filling it up. Please go through this. I found it useful. Hopefully, it will be useful to most of us. So this article was from the American Journal of Speech Language Pathology. So this is a very general request. If anybody from the group with a senior's help would like to do this for the Indian SLPs as well, to understand our workings, how we work, what is the shape and what is the flow and formation of how as SLPs we work in the country. So, or even in a particular region would come across as very helpful. Also, like I said, I chose this article mainly because it shows how intricately it is one of those intricacies while we are working with a child, instead of taking up a study which may or may not be clinically applicable to all of us. We all talk, so I just picked up this study. I am so I'll put this up on the chat here. It is a link to the drive. You can download this, and if you have the time, do come forward, do open up a discussion. Even if you don't do a extensive statistical study, you can still come up and sort of talk about this on this group. We are more than happy to discuss and take it forward. So if you have any questions, anything anecdotal, please, you can put it in the group chat, or we can wind up. So thank you so much for doing this on a Saturday evening, for coming out, supporting, helping with a nice, fruitful discussion. I think Priyanka ma'am's case was very nice in, one of the early intervened, first time intervened child, and the challenges that we face along the way, both as a SLP and as a privately practicing SLP. I'll try to get the recording out. So if any of your friends or any colleague has missed, they can also join in and enjoy this. So thank you so much, and thank you so much, and looking forward to more such discussions. So I'll give it a couple of more minutes, if anyone, if you want to download this article that I have just put up. Please come forward with your cases, how you are managing in your private practice, any case that you want to discuss that you have worked with for more than 1 year, more than 2, 3 years. Anything more than 1 year gives us a very nice perspective about how you have gone about from managing, like in this case, she said, from finances to parents to working with the counseling, working with the diagnosis, then actually the speech language part of it, and how we intricately discussed one aspect of our um, of our work, that is talking. So I hope all in all there was some takeaway from this. Thank you so much for coming, and thank you so much for attending and participating in the discussion. See you soon with the next meeting.